Hello, I'm Dr. Bill White. I'm a general dentist who has been doing nothing but orthodontics for the last 40 some odd years, and I'm a member of the American Orthodontic Society, which is a organization of general and pediatric dentists, and our sole purpose is to teach orthodontics to other general dentists and pediatric and any other dentist that's interested in doing orthodontics. So if you're interested in orthodontics, or if you're doing orthodontics, I encourage you to join the American Orthodontic Society. It's a very good society. We have a good program. We have a good journal, and we try to help anybody that gets into any trouble or difficulty with cases and things like that. We have a wonderful group of other instructors that are teaching orthodontics, and we have a tier method of passing boards. You have to work up to pass the boards, and once you pass the boards of the American Orthodontic Society, we know that you can do orthodontics. And so this is a very necessary thing, I feel, for general and pediatric dentists who want to include orthodontics in their practice. Now, I've covered the mechanics of impacted or not impacted, but tilted or straightening teeth up and everything. I've gone over the mechanics of it. I'm going to start in on the second phase of this phase of orthodontics. So here will be case number 2, and we'll go through several cases here showing you how we use this uprighting of teeth. This case right here is a case where it's an ectopically erupting tooth, which is just a good form of using this material. I'm going to get back over here, and I have a little marking pen here that I can mark on there where I'm talking about, so you'll help you understand or see what we're doing. This young lady's parents or her mother worked for another dentist that had a course we had, and she had this ectopically erupting tooth, and this of course isn't a very good situation, and she needed the mother knew what we had done, so she sent her over to me to try to get this done. Now when you look at this, the whole distal root of that deciduous tooth is resorbed away, but the tooth is still vital, and if you can get this tooth out of there, this tooth will make a good space maintainer, but you got to bring this tooth up something like that to do that. Well, we've uprighted teeth or set them up all kinds of ways, and this is pretty simple to do. Actually, if you weren't in braces at all, you wouldn't have to put any brackets on here. You could just bond a wire. This thing keeps coming up, but we'd bond a wire on these teeth, and then you make a little hook. Now the one we made here, I'll show a picture of the hook. It's just as efficient. Like you've got a tube, you have to bond that onto the tooth. It's tilting way down, and it could be actually, the tooth could be horizontal as far as that goes, and we could still bring it in if you just took a tooth that was something like that. You could bring it in. Now this one, we'll show you how we bring it up. We bonded a tube on the side of the tooth. You've got to be on the side of it, and you can make the spring on this either going down. This is a little more complicated, and you can activate it, but if you activate it very much, you can't try it in the tube. So we just activate it part of the way, and then you bring this wire up and where you're going to hang it and make a little hook in it. You just got a little deal like that. You hook over this wire, and then there's this tooth. You bring the wire up and hang it in there. Then it'll have a kind of a bowed situation. It's showing you that there's force on the wire. You can activate, or you can add to the force by going in there with one of these double optical pliers and put the little bar part under it and the big cup part over it, over the arch wire if you're going through here, and then you mash the arch wire, and this part of the arch wire would go down further, and it'd be more activation to bring the tooth up. Okay, let's just look at what happens here. Now, as you do this, this tooth is going to rotate somewhere down around here. And you say, well, it's going to run into this tooth up here, and it won't allow it to upright. That doesn't matter. You can go in and prop this thing up, and it'll bump that tooth, and it'll push it down, and this tooth will just upright. And actually, it'll pull it right out of here and have the tooth somewhere like that. Now, while you've still got this appliance in there, all you have to do is just go around behind it and put an elastic chain or something, and you can pull the tooth up and close the space up on the after it goes in there. So if you haven't done this, it is, to me, the simplest, best way to go into upright teeth. So here is the close-up of the tooth, and we're going to bond something on the side of it here and put a wire in there. You could either make the loop kind of like this, and then come in and raise it up and hook it, and we have a wire. We use brackets here. You don't really need the brackets. You can upright teeth. Just somebody comes in with a tilted wisdom tooth, you just bond about an 0.16 or 0.18 round arch wire on the teeth. Just make you some little loops and then put some bonding material on it, and you can raise this up and hook it over that, and it'll kick that tooth right out of there. Okay, let's see what we did. So here is the little device we've stuck on there, and we stuck it on the kind of the upper back side of the molar, and you see the molar is already started out of there. Now this hook was here, and as this tooth uprights, this spring moves back, and this hook is moved back on that little segmented wire we've got in there. Now this root in here is still holding the tooth in place. It's fine, and we want to use this as a space maintainer to bring that second bicuspid back up into place. Now here a little bit, just another few weeks or a week or two or so, the tooth went to this point. Now you see this hook was somewhere around here to start with, and now it's moved all the way back there. And this tooth that was down in this area right here now it's moved out that far, and it didn't matter if it ran into this tooth, it'll just bump it and keep it lined up, and it's lined up right with the rest of the teeth in here. Now, while you've got this spring in there, you can come over here and tie some elastic chain, and you can go back around this over here if you want to, and you can pull this forward. Now if you pull it forward, it's going to tend to lean, but then this spring will keep it straight up and down, and you pull it up against this, and you'll maintain this deciduous second molar as a space maintainer, and it's still a vital tooth, even though it looks like this is gone. But when it's eaten out like this, the nerve in the deciduous tooth is still vital. Now, let's see, after we got it up there, here I'm going to show it to you in the mouth. Now you got, it's not just a cup of tea doing it. I mean, you gotta have a little skill about it. But now we take electrosurge. You see how we trim that tissue off, trim it off down in here, and it kind of cauterizes it, and you can go in and bond you a tube on the side of the tooth. Now we take this spring, and it would just be activated a little bit as it goes in, because you got to push it in there and then raise it up and mark where your hook's going to be. Now the hook, notice, is right behind the bracket here. So we're going to be pushing down on a tooth that's got all of its root structure, and you can bond this here if you want to, or you don't even need the brackets. You can just bond a wire on this, and I'll show you some later on that we've done that. Now you build your hook where it's right behind one of the contact points, or where you bonded it together, because as this moves out, that hook, this whole wire is going to move back, and this hook will move back and be somewhere along in here when you get through with the case. All right, and there's the tooth. It's set up, and you see this hook that was right here. Now it's moved back to here, and this tooth that was down in underneath that root is moved out. It did not put any force to speak of on that weak part of that tooth. It just slipped it back. Now you bring this tooth back forward again to close that up against this, and now this tooth remains as a space maintainer until the other teeth are ready to come in. Now this is just the best way that I've found to do that. And there's the little spring that we use to pick that tooth up with. And you make your springs out of rectangular wire. You want something, if you make it out of round wire and you activate them very much, they tend to roll one way or the other. They roll over in the tube. Where you've got this rectangular wire in a rectangular tube, it doesn't do any rolling to speak of, unless it's a very small rectangular wire in a fairly large opening like that. All right, here's another case that we had transferred in. This young lady had her lower 6-year molars apparently were bad, and no, I'll take it back. Let me look here. Wasn't her 6-year molars, or was she apparently had no second bicuspids, and they apparently took the deciduous teeth out, and she's got a real nice class 1 relationship and everything. They were just waiting there. They were going to plan to put either implants or bridges in this young lady's mouth. And she came in, and I x-rayed her, and lo and behold, she's got wisdom teeth back in underneath here on both sides, lower and upper wisdom teeth. So I sat down with the young lady, and I said, if you don't mind taking a little time, I can move these teeth right up to here, you see, and you won't need any bridges, and you won't have to have your wisdom teeth out, because I'm going to move them up. There'll be the 6-year molar and the second molar, 12-year molar, and then the wisdom tooth back there. Now, this is frowned on. I mean, some orthodontists just don't think that can be done, or they don't want to do it. I was talking to an orthodontist friend of mine, said, well, his granddaughter was that way, and the orthodontist didn't want to do that at all, and he insisted, and so they did. But you think you can't pull this tooth into a knife edge ridge like that, but you certainly can. Now as the tooth comes forward, it brings its own bone with it. It'll just move up here. You can just look at it as we get through it. Now this is what I would want in my mouth, and I think it's what you would want in your own mouth, or your granddaughter, or your daughter, or your wife, or so let's start doing this. It's ridiculous, to come in here and put a bridge you can't put the implant till the young lady's completely grown. Maybe she is. And if you do, you have to split this and spread it apart and put some freeze-dried bone in there, widen it out enough so you can get a dadgum implant in the area. Whereas you can just pull it together and you're going to save your own teeth. You won't lose your wisdom tooth, and you can spend the rest of your life with your own teeth in there rather than an implant, which could go bad. They're real good nowadays and they're holding up, but that's an artificial tooth that you've got in there that you're going to have. This young lady, I don't remember just what her age was, but she may have her teeth, but she's 105. I don't know. And it's so much better to have your own teeth than the implant or anything you can stick in there. There's nothing as good as your natural teeth. So anyway, she decided to go ahead, and she wouldn't mind taking a little bit longer to do this. And here it is, and you can see the wisdom tooth back here. So when we close this up, we're going to have the 6-year molar is going to be under the bicuspid, of course, and then the second molar is going to be under part of the first molar up above, and then this wisdom tooth will come under a portion of the upper 12-year molar, plus some of the upper wisdom tooth will come down and touch it. Now, you think if you move the second molar out in front of the wisdom tooth, then it would straighten up, but this one did not. Now, some dentists would throw up their hands and, well, the wisdom tooth isn't straight. How can we get it in there? You can straighten a wisdom tooth up after 3 years or 10 years after you finish the case. If one comes in, it's got room, all you have to do is just bond a little wire on about 3 or 4 teeth over there and put one of these uprighting springs on the wisdom tooth, and you can pick it up. All right, so we start out here and just watch it go. Now, excuse me, in our organization, we had some of the teachers or instructors got sold on the idea of never taking any teeth out and never doing anything, so they didn't teach some of the people how to actually bring molars or bicuspids or anything forward bodily. And what we do, we're pulling on it, but we take the arch wire and come back and we put a little circle like that a lot of times. Then we'll go down. Now you got to activate that up, see, to go in the molar. Well, the wire is pushing down on the roots, and as you come in and tie or you close with that, and the wire closing, this wire being tipped down like that makes this root go along with the crown. And if your crown starts to lean too much, then you either need more tip or less force pulling in. If the crown is dragging and the roots are going in front of it, then you've got too much of this tip or not enough force trying to pull the crown forward. You can control it just right down to a T. Now, if you're pulling these teeth forward with a certain amount of force, you're going to be pulling these backward with exactly the same amount of force. Now, say you don't want these teeth to go backwards at all, then you have to close it with class 2 elastics. You come back here and hook up with class 2 elastics. And you can use some force from the front, and as your class 2 elastics pull your anterior teeth back, then you keep them in a class 1 relationship up here related to the lower teeth. And you do that with class 2 elastics. we did not use these tads. Now, what we're doing now with some, if we do not want to move these teeth at all, we come in the cortical bone over here and put a tad. And it doesn't have to touch the bicuspid, but be right there close. And then we bond that tad to the bicuspid with a good a good composite that's really stout. And we etch that bicuspid so it really holds good on it. And this tad is in the bone, so it was very hard to move one of them. I mean, you almost can't move them unless you move the whole segment of bone, and you'd have a tad over here too, And then you can pull these teeth forward, and these would not move back at all. But if you don't mind reducing the profile out here a little bit, you can wear class 2 elastics to pull these teeth forward. And then you just watch the bottom and upper and lower teeth right here, how they meet. You can pull on this some along with the elastics to keep this lined up like that. I hope you understand that. It's not, I didn't go through it too clear, but that's the way we're doing it now. We use the tads. That's the best. It doesn't let, if you don't want to bring back. Now, if I want to reduce the profile a little bit, then you got it made. You just wear class 2 elastics and pull it back. Okay. Now, a lot of people, and that includes orthodontists, do not think you can move a tooth into a knife edge bone situation, but you darn sure can. So I don't want you to, I'm not grappling with the orthodontist. They've been taught that. Apparently somebody down the line couldn't do it, and so he told everybody else you can't do it. I didn't learn mine all through the orthodontic school, so nobody told me I couldn't do it, and I've done it. And so I want to pass that on to you. And I've been teaching this and lecturing with it for years, and still people aren't doing it. So that's why I'm trying to go through this stuff and put it on a video and try to put it on YouTube or Vimeo or whatever the heck it is, and just let it go out all over the world if people want to learn about it. So here we're coming in. Now we use an omega here, but the end of this archway would be going down, something like that, and you raise it up and hook it. Then you tie this back, and it'll come forward. The roots will come forward with the crown. If you watch this, you can kind of see that happening. We didn't do it perfect, but that's basically what we were doing here. So this is, she's 17 years old, by the way, up there. Now we have, let me see how long this took. That was 12/22 of 87, and here it's 10/3 of 88. So it wasn't quite a year we had this together. Now I got the molars up here pretty good. They're going to have the angle to them. I need to put more tip in these bicuspids and bring this root up too, you see. I didn't have enough tip in those, but you put a little tip such as this in here, angle down, and you can bring these roots up so that this would be lined up, the cuspids and bicuspids and everything, and closed it up. Now what I was showing this case, the wisdom teeth, as I came forward with this, we moved them a long way. The wisdom teeth just kind of slid along behind us. Now, let me go back and look where those teeth were, and you see where the wisdom tooth is. You'd think, well, I'll slide these teeth out from under this, And the wisdom tooth is open, and it'll turn and go up like this. But there are a lot of transeptal fibers and everything attaching these teeth that are kind of been together all this time. And so when I move this forward, the wisdom tooth uprighted a little bit, but it didn't do much. And so a lot of people would just throw up a hand, oh my God, you know, we've screwed up now, we pull this up, and you have it even if you didn't get the wisdom tooth in, you still got this tooth that's supported by the back part of that. It'd be better than, I'd rather spend my life without the wisdom teeth and out these teeth and not have any, prosthetic appliance in there at all, you know. But now we don't have to do that because we know how to pick them up and to upright them. And I want each person, wherever you are, to learn how to do this. It's really not that difficult a thing to do. Okay, so here's the tooth, and the darn thing, one of them straightened up a little bit, the other one just darn near lay down. And so don't worry about it. You got to bond something on it, but you have to bond on a little corner of it, you see. And then you pick it up if necessary. You could do a rebond, but I think we got it up there without doing anything else. Now this one's pretty easy over here on the left side of the mouth. The right one, though, was a real booger. It wanted to lay down, and I guess it was tired. So anyway, we're going to come back, and so I bonded this little deal on the side. You can see it just a little bit back in here, and it's already moved up some. This one we bonded a little and it's already in place, you know, no problem at all. Now let's see, we go a little bit longer, and I had this deal on the side of it, and I picked that whole tooth up and it was darn near horizontal in here. The molars are together. That's some cortical bone or something, and it looks like a deciduous root tip in there. We didn't bring that tooth forward like put enough distal root tip in it. I don't eat neither one of them, so you learn, you put it on here and you start to show somebody, think, oh, I screwed up there. The crown may look fine, and it's not all that bad, but it could be a lot better if we did that. So now we put her in a retainer, and I hadn't got the upper wisdom teeth in, so it just went right behind here. And then after this tooth gets in good, you really should go back and make another retainer, because you got something there interfering, coming through that gap. Now on the bottom I had a 3 to 3, it looks like, in there, and we still didn't tip those teeth back, and I'm sorry for that, but this young lady will have these teeth, and maybe over a period of years that thing may occlude up here and angle a little bit, and then it may get a little better, but that's not really good in that respect. But look where that molar is, and that it was a knife edge ridge, and it's in there. Now when you look in the mouth, this was the knife edge ridge, and you can't tell that was there at all. Here you got a little cleavage in that, but not much. You can see it, but that tooth is together, and I would much rather have this in my mouth than have a dead gum implant. And to fix it up with implants at the price they are now, you're talking about nearly $3,000 or $4,000 or maybe $5,000 a tooth to do that. So we were able to put her natural teeth in there. It just took a little longer to do it, And I think people deserve that choice rather than going in there and do that. Now, when some orthodontists just really oppose this, I don't know why on earth they would, but that's the way it is. So I hope that you realize you can do it and people will go ahead and do that. Now you can see where the space was and you see where the teeth are now. And these teeth we cocked back a little bit, you see, to give them more resistance to pulling that forward. Is where you see there's a little more torque in these teeth than there is in these over here. So we dug the roots in, and that helped us get anchorage to bring these teeth forward like that. Now this is not terribly difficult orthodontics. So I don't think because the orthodontists don't do it that you can't do it, but you can do that. So don't be afraid to try. Now here's another case, number 4. This young lady had a real problem growing up. The teeth, she's got a crossbite back in here and a whole bunch of problems here. Now get around here and look at it in a Panorex, and so we expanded the palate, and we had impacted teeth down in there. You see, these are the 4 anterior teeth, and we got impacted cuspids down in here, and so we're going to have to really develop this out to get all those teeth in there. Now I felt like it would be better to do that. We've got a kind of a flat facial profile. I would rather fill her face out a little bit more. I hope I didn't take any teeth out after selling you on that. We put a palatal separator, and I like to band every tooth, and when I go apart with it, it has a grip on that tooth. It doesn't just bring the crown out, it brings the root and all out. And it'll kind of tilt when it first starts out, and then they chew on the lingual cusp, and I leave them in 7 or 8 months before we take them out, and this tension works its way on that, and it'll bring the root structure of the teeth out. So here we are later down the line, and we've got it lined up like such. The upper, we've kind of expanded both arches. You see, these teeth were extremely crowded. The cuspid was down in here. We bring the cuspid, we expand the cuspids, we expand the whole mouth. And a lot of people are taught that you can't move the cuspids out at all, or they're going to come back and it'll collapse and do all this stuff. But if you bring that cuspid back and angle the root like it should be, like the rest of the teeth going back, the cuspid doesn't have any sacred knowledge or position that it's got to go up here and got to work in that spot. But there are people that believe it does. And if you move it back, it's going to come back. I've got cases where I've expanded cuspids and the space is almost twice what it was when we started, and some of them have been out 30 years and they're still back there, so they're going to have to hurry up. All right, now this young lady had a tooth that had a problem back in here, and they went and the oral surgeon put some clips, and I never did really find out exactly what the problem was here. Even got a clip down in this area, here and here. We just went ahead and worked with the clip, but this tooth is ankylosed, so we couldn't upright it. We could move it or expand it if you bring the whole bone structure out the tooth. The ankylosed tooth moves with the bus. If you move the whole bus, you see, it doesn't have any choice but to move. So you do, or you can, move ankylosed teeth. If you just move the whole alveolar bone structure up there, they move right along with it. And I always think of it as the tooth on the bus, and you move the bus, the tooth moves. So, and they may sit steady in its relation to the bus, but just moves out. It'll move along with it. All right, so we got a crowded situation up here, crowded situation up here, and it's crowded as old get out down here. Now, I'm not a dead set on expanding everybody. I take some teeth out when they need to be, and when they don't, I'll try to leave them. All right, we expanded the palate. We went in and expanded the lower arch. Now we've got a pretty decent space there for the teeth to come in. Not all that they need, but this will amaze you what you can do. This tooth's a little bigger, and let that buy in. It's rotated some, and we can expand it and bring this tooth in place and everything. Now we've gone in, we've expanded that lower and the upper, and we've got arch wires in there to expand. This tooth right here now is what we're about uprighting. If you don't know how to upright one, then you're up against a real stump on this case right here. You're going to come back and say, God, I would have to extract this tooth, or just learn how to upright the darn thing. See, that's the way to do it. And I hope you can take this little video and learn. You can, if you pull it up, you can go back and forth over it 50 times if you need to see what you need to do to it. Now this tooth was ankylosed. I wasn't able to straighten it out very good right there. But I could expand it along with the rest of the teeth. So don't think that you can't move the darn thing. I mean, if it's sitting on the bus and you push the whole alveolar bone structure out, it goes with the whole bone structure. So we expanded the tooth, even though it's ankylosed, and a lot of people say, oh God, we can't do anything with that tooth, it's ankylosed. But you can do a lot. And I've brought them in that are impacted, that are ankylosed. You have to break them loose that way because you're moving them within the alveolar bone that it's ankylosed in. So anyway, got these clips, but I never did talk to the oral surgeon that put these in. I guess when she was real young, and why, I haven't really figured out. Okay, so here's a nice little problem. Now you just take your electrosurge and go over and trim the tissue off that buccal side of that tooth, and stick you a little tube on the side of it, and come out of there with a little spring, and that's about all you could stick into that tube, the activation. And you stick it in, pull it up, mark where you're going to put the hook, take it, put it back in, bring it back up, and now your wire will be kind of bowed up like that. Then you can put more activation if you want to, and you'll just take that tooth, which I don't know what makes that white deal come up, but it bugs the heck out of me. Now, this will raise right up out of that spot. There it is. I mean, we stuck a deal on there. I don't know how long that took. This is 5 of 86. Now, 5 of 86. And I'm going to go back, and this is 8/30 of 85. So 8 would be, that's almost the end of 8. So we got 9, 10, and 11, and 12. We've got that's the end of 8, so we still got 4 months there and 5 months in the other. So it took a while to do that, but look what we've got when we get through with it, you see. Now here we're going to hook it, bring it up. Now we were doing a lot of other work in there. This tooth is still the ankylous one. This one's setting up now, and this will come down and work against it. This will come in over here. She's got a wisdom tooth here, and one here and here. I can't tell for sure whether there's one there. Now they may have room. If they have room, I keep the wisdom teeth. She's got a flat facial profile, so we expanded her mouth to make her look better. And we're going to wear retention like mad, you know, to keep it that way. So here's that tooth we set up with that thing bonded on the side of it like that. Now this is 1986. All right, here it is, 1987. We're keeping it in here a long time. I'm holding it, kind of hoping that 12-year molar would come down. Now, a lot of times things that delay your treatment is waiting for teeth to erupt into the mouth. Now, you can finish the case and put a retainer that just kind of comes, or if you can get around, you can put it around, leave an opening there that can come down. But we just stayed on longer on the case. Now we've finished it now, and we've still, the 12-year molar above hadn't come in, but we got this tooth up good, so this is going to come down, sit on that. This doesn't look like it can make it. Now, if the jaw had room enough, you could upright down, upright this, and bring those in, but I'm not sure what we did with that. Let me see. All right, we elected to have those wisdom teeth extracted, and there may be several factors why we decided to do that. This is kind of a super class 1 situation, and so it's a little class 3-ish there actually. Okay, here it is, really finished out where we were, and the wisdom teeth are gone, and the teeth are occluding quite well, just a slight class 3 problem over there. Okay, here is the young lady later on. She's still not protrusive, you know, but she's got a beautiful smile, you know. And if you remember what she looked like to start with, that's a big improvement over that. And if she takes care of that, she can have those teeth the rest of her life, you know. So this is 91. That's several years later, but she has a gorgeous set of teeth. Now the second molar up above on that side is way in, and I guess when I separated the palate I didn't get that one out where I wanted it to, but you can't detect it looking at that, but that's still not right. I should have done that. And the lower looks like that. You know, it was crowded as all get out. We expanded the lower, got the cuspids in. And I think that if I could find that girl today, or that young lady, that was 91, was way after we had finished the case. So 91 to 2001 to 2011, and now to 2015, and you know, she's probably still got a very nice set of teeth. Now, people say you cannot do this. You see, how narrow this is right in here. Well, there it is. And it's been there a good while already. And I'll bet you if you could find this girl 25 years later, that these cuspids still have not crawled back over, that she may have a little crowding or something like that. I run on some of these people every once in a while, and they still look good, see. So my objective is make them look as good as you can, and then retain the heck out of it if you have to. Now, if you get teeth out of the normal balance, and if the tongue doesn't adapt to it and round out and keep pressure on them, then it'll come back in. So we wear the retainer for years. On some of these cases, I want people to wear them the rest of their life, you know. Okay, here is case number 5, uprighting wisdom teeth. There's room, then we always try to keep the wisdom teeth. They're actually the best position of any tooth in the mouth, underneath the muscle. Your muscle structure comes down right in this area, and so this tooth you can chew better in the very back of your mouth than you can in the front for sure. And so this girl came in, got plenty of room for this wisdom tooth. All we have to do is just bond a little wire. It doesn't take but just a minute. Stick it on it, bond it on, bond your tube on the tooth. If you need to take electrosurge and open it up, put your little spring in there like that, bring it up, see where you want to put your hook, make your hook, put it back in, activate it, and then come in here. If you want to really activate it, you take that optical plier, it's got that cupped in area, just mash that, you make that wire go down like that. Now you can't try it in when the wire's going down like that, so you have to have the thing hooked up and it'll be bowed already, and then when you press on it, it'll really bow this, and that'll just kick that thing right out of there. It'll run up against that, and that'll level it out, and that'll be all there is to it. So there it is, there's bonded. You can upright one almost as simple. If it was a real gem impaction, you can do it quicker. But rather than just take that tooth out, man, if it's in my mouth, keep the wisdom teeth. If you have room for them, they're in the best chewing position in the mouth. So there it is. Didn't have my final picture in here. I don't know what I got her back or didn't get her back or something, but that was where it is. Upright in the lower second molars. Well, this one is not. This was done years and years ago simply by an arch wire, that we were able to devise an arch wire to do the same thing, and I don't advocate learning that, because you can just upright these teeth so much easier with that little spring. So anyway, we did this lady. She worked, but this was 1974, before we had brackets and stuff. We were still using bands, and that back then we didn't have good bonding material or brackets or tubes and things, but we learned how to set the teeth up like that. All right, here's a case that we finished the orthodontics, and the wisdom teeth came in, and we were finished with the orthodontics, and I don't know, the wisdom teeth weren't in yet, or the 12-year molars, I'm sorry. 12-year molars weren't in. I guess 14, nearly 15. So some people that don't have wisdom teeth, their 12-year molars are really 14 or 15-year molars. They're kind of split the difference. Okay, here's he's 15 and 8 now, and the wisdom teeth are just now coming in. And so as they get in, he's wearing a retainer. We just came and bonded this little wire onto the teeth and uprighted those teeth like that. Now, this is good orthodontics. Now, if you're a general dentist, you have this patient and you watch him for years. Now, orthodontists are at a disadvantage. They see them, but I don't know when this guy first came in, but it was years ago. And then these teeth come in, you come back and straighten them out for them. And you have a better advantage to do that than the orthodontist does. And orthodontists don't even like to give shots. They don't like to do surgery. You know how to do surgery, and you know how to give shots. You know how to do a heck of a lot of things that help you in doing orthodontics and fixing it up right. So I hope you have picked up some ideas from this. Now here's the way we bonded that on. Now don't get all tied up because the tissue's over the tooth. You have electrosurge, you know how to use them, you deaden it a little bit, go in there and take that tissue off, bond this deal on the side of the tooth. You can do that, bond a wire on there, make this little simple spring, go up there and put that in, and you can straighten that darn tooth out. And you keep the wisdom teeth. And there it was. I activated that and tied it up. You don't have to do that either. You can go in and activate it like I showed earlier. Bond that thing on the side. And I hope I've got to finish. Yeah, here we go. It's just about in there now. It was like that. Now it's in there, see. And the person has a good tooth back there. That's not hard to do. Charge them whatever you feel like it's worth to them. It's good to do this. Now they can clean the tooth, take care of it, and save it. And this is all I've got on uprighting teeth. And so I'm going to move over here and just stop this.